Creatine ethyl ester has the unusual distinction of having its core marketing claim disproved by the most methodologically rigorous trial ever conducted on that specific product. The marketing premise was that attaching an ethyl ester group to creatine would dramatically improve absorption. Esterification is a genuine pharmacological strategy. Many drugs are delivered as prodrugs in esterified form because the ester group improves membrane permeability and lipid solubility, allowing faster and more complete absorption. The creatine ethyl ester hypothesis was that the same principle would apply, with the ester enabling creatine to cross cell membranes more readily and bypassing the need for the creatine transporter. It was a plausible idea. The problem was what happens to an ester group in the gastrointestinal tract. Esterases, yestai, enzymes that cleave ester bonds, are abundant in the small intestine, the pancreatic secretions, and in the blood. When creatine ethyl ester encounters these esterases, the ester bond is cleaved. But the product of that cleavage is creatinine, not creatine. The ethyl ester is hydrolysed to ethanol, a tiny amount, and what remains is creatinine, the inactive metabolite of creatine that cannot contribute to phosphocreatine synthesis in muscle. This is the central problem. The esterification route that was supposed to improve delivery instead routes creatine through a degradation pathway. Rather than liberating free creatine for absorption, the ester hydrolysis produces creatinine. The Spillane et al. Study published in the Journal of the International Society of Sports Nutrition in 2009 tested this directly. Participants were randomized to creatine monohydrate, creatine ethyl ester, or placebo over 47 days. Muscle creatine levels were measured by biopsy. Blood creatine and creatinine levels were tracked. Strength and body composition outcomes were assessed. The results were unambiguous. The monohydrate group showed significant increases in muscle creatine content. The creatine ethyl ester group showed no significant increase in muscle creatine and had substantially elevated blood creatinine levels throughout the supplementation period. Consistent with rapid conversion of creatine ethyl ester to creatinine in the gut and bloodstream, creatine ethyl ester did not load muscle creatine. Monohydrate did. The CEE group's elevated creatinine confirmed the degradation pathway that the mechanistic analysis predicted. The 47-day study period also coincided with the height of creatine ethyl ester's commercial popularity. Products were being sold internationally based on the esterification rationale. The Spillane study was published during this period and represented a direct clinical refutation of the premise. Performance outcomes in the Spillane trial matched the muscle loading data. The monohydrate group showed significantly greater improvements in strength and lean mass than the creatine ethyl ester group, which performed comparably to placebo. Creatine ethyl ester continued to be sold after this trial, though it has since declined in market share as the evidence became impossible to ignore. It represents a case where a biochemical rationale that was sound in principle failed entirely in the specific application. Because the gut environment it had to survive was not considered carefully enough when the product was designed. The ethyl ester story is an instructive example of why plausible mechanism is not sufficient evidence in supplement science. The mechanism had to survive contact with the actual human digestive system, and it didn't. The ethyl ester story also illustrates a failure mode in supplement development that recurs across multiple product categories. Assuming that a pharmacological principle demonstrated with drug molecules will translate directly to a nutritional compound. Esterification works for certain drug prodrugs because those drugs have specific membrane permeability challenges and specific metabolic activation pathways that make the ester approach effective. Creatine's challenge was never membrane permeability. It has a dedicated transporter and is absorbed efficiently from the gut. The ester addition did not solve a real problem with creatine delivery. The creatinine elevation seen in the Spillane trial has health implications worth noting. Blood creatinine is a standard clinical marker of kidney function, and elevated creatinine triggers concern in clinical contexts. People supplementing creatine ethyl ester were producing abnormally elevated creatinine levels without the muscle loading benefit. If those individuals had their kidney function assessed during supplementation, which some did without knowing the cause, they could have received a misleading signal about renal health.